Thanks, Mr. Chairman. This is St. George's Hospital in 1908. It's changed a little since those days. This is Hyde Park Corner, close to Piccadilly, so it's the centre of London. Now it's a swirling mess of traffic, of course. And the big building you see there was St. George's Hospital until it became a luxury hotel about 15 years ago. So the real St. George's is now a skyscraper downtown. You might wonder what is a neurologist talking about costs for, because we're not supposed to be interested in money, are we? But what struck me in the last 10 years in England is the fact that medical legal costs are escalating rapidly. They're catching up with the States. The data are that there were 500 cases in 2006, which is 8,000 in 2010. Now, I imagine it's closer to 10,000 by now. So something is happening in terms of the expenses of medical litigation. In the US, healthcare costs were expanding from 4.6 in 1950 to 17% in 2009. The trouble is that US managed healthcare is really by private insurance, whereas in England, of course, most healthcare is by the taxpayer who has to foot the bill. Now, stroke is the third most common cause of death in the Western world, and probably the most common form of chronic disability, dwarfing all other neurological illnesses. So it's a very expensive item. And it's becoming more expensive, I think, because even though there's a magical cure now for it, as we've all heard, it doesn't seem to be catching on. Now, thrombolysis in eligible patients is usually a fairly inexpensive business. For instance, complicated migraine. These are the patients that we've all seen, I'm sure, in acute stroke units. Hyperglycemic episodes, post-ictal hemiparesis, quite a common one. Psychogenic strokes. We had a patient a year or so ago, was a middle-aged man who came in the middle of the night and was thrombolyzed. The next morning was very attention-seeking and said that he'd already been thrombolyzed in another hospital in London just a month or so ago, and when we sent for the medical notes of that patient, he'd already been thrombolyzed twice there before. So he was a TPA addict, in fact. Subarachnoid hemorrhage, of course, is a bad thing to miss, which you probably less so in CT than you would on MR scanning, I suspect. And occasionally, MS plaques may look like TIAs if you don't do an MR scan. But what are the expensive patients? Well, these are patients who, for some reason or other, cannot be delivered to hospital on time for various reasons. A common reason is that the wife diagnoses a stroke, but the GP comes around to see them and says, leave him till tomorrow morning, he'll be okay, it probably isn't a stroke. Delayed diagnosis in the hospital is not uncommon. There are junior people on at night time in any hospital, I'm sure, not just the UK, and they fumble around and they decide to leave the patient till tomorrow morning, till the chief sees the patient, by which, of course, it's all too late. Delayed transport to hospital was a common problem, but it's now becoming much less so. Sometimes urgent CT scanning wasn't available, but again, that's being cured. And of course, there's always a possibility of a wake-up stroke when you don't know what time the patient had his stroke, so he's not thrombolyzed. Here's an interesting patient, a young woman who came in a few years ago with a hemiparesis, and she was not thrombolyzed because she wasn't a suitable patient, and she only had a CT scan which showed nothing. She came in a year or so later with another episode of hemiparesis. This time she had a CT which again was normal, but the MR scan showed the offending plaque. We've heard all about Ken Butcher and whether you should use CT perfusion or CT scanning. Although, in fact, if you take a consensus of units, in the Western world at least, and particularly the States, 95% of patients are scanned with CT and not MR scanning for various reasons, because it's more convenient, it's easier, you can give the injection in the machine, etc. But in reality, of course, the problem about CT scanning is that a negative scan is a positive indication, which is not a good, a logical way of doing things. if you use MRA mismatch, as you see here, with a DWI small, the cellular death is a small area, but a large area of perfusion deficit, then you can give the TPA more logically, I think. So how can we avoid mistakes and reduce the huge expenses of acute ischemic stroke care? Well, they're working on it in the UK, and this is very much a UK-orientated talk. There's something called SNAP, which is a UK audit of all units in the UK, a rather ambitious project, but what it consists of essentially is ensuring that the stroke hospitals which are certified have a stroke team 24-hour around the clock with 24-hour scanning and the appropriate backup of an acute stroke unit. Maybe, as someone just mentioned previously, I think it was Michael, that really the stroke unit is the primary treatment of stroke, in fact, funnily enough. It's not TPA, it's really a stroke unit. So if the hospital does not measure up to the audit and does not have the appropriate facilities, then the certificate or the audit is removed from them. And if that happens, it's very bad news for the hospital, because the ambulances are then diverted to a hospital that has an acute stroke or hyperacute stroke services with 24-hour round-the-clock nursing team, medical team, and thrombolysis, so that it hurts them to lose funding for the hospital. So there's a lot of interest in the UK audit. It's still in its infancy at the moment. I think mobile stroke vans are going to be useful. At the moment, of course, some, as you probably know, some countries do have CT vans with a CT scan in them, sometimes even a doctor in the ambulance. And I don't see why we can't arrange an MR scanner in a van, in fact, for more accurate diagnosis, so that you could even start the treatment in the van, and you can certainly make a proper diagnosis on mismatch in the van. So as you can see, I'm sort of orientated to MR scanning rather than CT scanning in stroke. Now, I've had some experience of telemedicine. I was in the American Academy meeting in San Diego a month or so ago, and I was actually involved. They gave us a real live demonstration of telemedicine. It sounds like a good idea. I was very unimpressed, I must admit. It's very difficult to diagnose a patient with just a relative speaking through a television. And I wonder whether or not the lawyers would like the idea that you missed the diagnosis but shouldn't have under normal circumstances. So I'm not quite sure where telemedicine fits. It doesn't probably fit in England because the country's too densely packed. It might fit better in a more mountainous country where there's less access to acute stroke services. And I think the most important thing about a stroke center is to supply not just IV TPA, but more importantly, I think IA TPA, because I believe that mechanical embolectomy is going to be the answer, in fact. And if you read the recent advances in the removal of embolus, it's quite clear that the dangerous short 3-hour interval is going to be expanded. It was 4.5 with ECAS, but with embolectomy, it can be extended probably as long as 8 hours. Now, if you have an 8-hour gap, you have time to do proper MR scanning and to look at the patient carefully. I'm not saying you should delay, of course, giving thrombolysis, but you have more time to do things. And I suspect that IV TPA may die a death. I suspect TPA has a limited lifespan in terms of the future, and I believe that embolectomy is going to be the treatment with a device or with suction or some way of getting that clot out. Because the problem, of course, about all TPA is that when you have a blocked artery like the ICA, TPA is not going to get there. You have to remove it mechanically. And since the great majority of these patients have got blockage of a large artery, it may be posterior circulation, maybe anterior circulation, but if you have a blockage like that, you haven't got a chance of getting it out, because when the clot's removed, it's a centimeter or so long. IV TPA is never going to be able to dissolve that clot. So Fifthly, I should mention the new thrombolytics. We've been talking about them for some time, tenecteplase and desmoteplase. We've heard good things about them. I haven't seen anything positive yet in terms of statistics, however. And finally, I started out with St. George's. Here's Dr. Henry Gray, who wrote the famous textbook that you all know about and is still used widely at least in the English-speaking world. He was a St. George's student and a St. George's consultant, and he just finished his anatomy in the nick of time because he died 3 years later from a smallpox epidemic in London. Thank you.